Thank you, Amit, for a very nice overview on staging. So my job in the next 10 minutes is to speak about functional or metabolic imaging and its incremental value in lung cancer staging. How do I? So in the metabolic imaging or functional imaging basically is PET scan, and in the interest of time, I'll restrict myself to the use of FDG PET CT in lung cancer staging. Yeah, third one. Regular mode में जाना. So I'll straight away get to the topic. So why staging is important? Amit said that prognosis and outcome depends on stage, and your optimal treatment varies with stage. As he showed, as your stage increases, your survival drops from more than 90% in T1 cancers to less than 40%. Same for nodal disease from survival. There's significant drop of survival, 5-year survival from N0 to N3, and even for metastatic disease, even from M1A to M1C, there is more than 50% reduction in survival. So its survival is critical, and we need proper staging modalities which will kind of prognosticate the patient. So if you look at NCCN guidelines, across all stages, FDG PET-CT is recommended as an essential staging modality for a proven lung cancer. So this is just a slide which tells us about T descriptors. Essentially they are size-based, based on size criteria, and also what a tumor does to the adjacent structures like the bronchi or the mediastinal vessels or the chest wall or the pleura. So if you look at T1, it's essentially a size-based criteria. So this is a T1 lung cancer on CT scan. Do you need any other modality to upstage it? No. So even if you do a PET scan, it shows uptake. FDG PET-CT does not add any additional value. Now, if you look at T2 is the same as T1. If you look at T3 lung cancer, this is a centrally situated lung cancer, which is infiltrating the mediastinal pleura, but the great vessels are not involved. So this is a T3 lung cancer. You do a PET-CT scan, it doesn't add any additional value. Coming to T4 lung cancers, T4 lung cancers are those which infiltrate the mediastinal great vessels, the vertebral body, etc. So these are two examples of T4 lung cancers involving the pulmonary artery, and in the second case, aorta and the vertebral body. Very clearly, CT scan tells you everything. It's not going to upstage here. There's no T5. PET-CT essentially shows the same. So is there any incremental value? There's no incremental value here also. So for T-staging, the modality of choice is a contrast-enhanced CT scan. Now, if you do a PET-CT with contrast, it can provide a similar information as a CE-CT scan. Chest radiographs we know are of limited value, though they can provide some information. MRI is usually not a preferred modality for T-staging except for Pancoast tumors or tumors which are very close to the heart to look at myocardial invasion, but those are isolated cases. By and large, MR is not a preferred modality. So where does PET-CT help in T-staging? For example, this is like an opacity in the right upper lobe. Bronchoscopy has shown malignant cells. It's very difficult to demarcate what is tumor, what is consolidation. So in some cases like this, when the PET-CT shows a central tumor with the surrounding atelectasis, it can, demarcate the lesion and the surrounding consolidation well. So that's where PET-CT can help in T-staging. Sometimes when a tumor, a soft tissue, abuts the chest wall and you really don't know whether it's involved. So when sometimes PET-CT can tell you that there is again tumor which is away from the soft tissue, which is just probably consolidation or peritumoral atelectasis which is abutting the chest wall. So it can occasionally help in such cases. But by and large, CE-CT will tell you everything. Coming to nodal staging, we know that N1, N2 nodes are basically stage 3 and surgical option, whereas N3 onwards, it's a non-surgical treatment option. So if you compare CT and chest, literature-wise, PET-CT has a higher diagnostic accuracy compared to CT scan in Western literatures, because it can pick up smaller nodes which are by size criteria called as negative on CT scan. For example, this is a left-sided lung cancer. You can see a contralateral small lymph node about 7 millimeters, which would be negative by the CT size criteria, but you can see that there is intense uptake. So such nodes, this was a HPR positive mediastinal nodal metastases. Now, when you look at nodal staging for PET, if you look at various countries and their data, you can see that the negative predictive value of PET scan for mediastinal nodal disease is very high, upwards of 90%. But if you look at the positive predictive value, it's quite modest, around 70%. Now, when we looked at our own data at Tata Hospital, our NPV was also very high, above 90%, but our positive predictive value was just about 50%, means that if the PET scan is positive for mediastinal node, it's just like a toss of a coin. It could be positive or it could be negative. And the reason for that is because of the presence of granulomatous and inflammatory adenopathy in our country. So this is a lung cancer with multiple mediastinal nodes and another lung cancer with mediastinal nodes. One of them is TB and one of them is cancer. So this is how, both conditions can confuse if you just look at the uptake, and there's no real easy solution to it except for mediastinal nodal sampling. It could be by EBUS or it could be by invasive mediastinal staging. So for nodal disease, TB or not to be, false positive PET remains a challenge. Positive PET CT, you need to sample the mediastinal nodes either by EBUS or mediastinoscopy. A negative predictive value has a higher NPV, but we still do invasive mediastinoscopy in most cases, because you can have about 10 to 12% false negative PET scans. For metastatic disease, we know what M1A is, which is intrathoracic mets. M1B is solitary extrathoracic, and M1C is multiple extrathoracic. So for M1A, CT scan will tell you almost everything, intrathoracic mets. For M1B and M1C, there are several modalities, including CT scan, your age-old bone scan to look at bone metastasis, PET scan, and MRI brain. But in the last decade or so, a combination of PET and MRI brain will map out all possible metastatic sites for staging. And we know that when you have metastatic disease, it's systemic staging. So now, why has PET scan become a standard imaging modality? Because there has been level 1 evidence. Now, PET lung cancer was the first cancer where PET was subjected to randomized trial, so which has been published in Lancet, JCO, and NEJM. And they used PET in one arm and conventional workup in another arm for early stage lung cancer. And you can see that in almost 20% of cases, futile thoracotomies were prevented in the PET arm, and that was primarily because of detection of asymptomatic distant metastases which were missed on the conventional workup. So this is a juicy T2 lung cancer. You can see most surgeons would want to operate it. If you look at the CT, there is nothing which is obviously seen, but you can see the small foci on the PET scan seen by red arrows, and they were actually tiny peritoneal metastatic disease. So a patient which was T2 N0, M0, which could have been operated, now becomes M1 and needs systemic therapy. Similarly, this is again looks like a locally advanced lung cancer which would probably need radiation. You can see on PET CT these small chest wall and skeletal metastases which otherwise would have been missed. So a patient which could have been either operated or treated with radical intent now becomes M1 and needs chemotherapy. Sometimes you have these tiny films of pleural effusion which we don't know whether it's just a syn mnemonic or reactive effusion, and occasionally PET CT can help in such cases by detecting these tiny deposits. When you have these PET CT avid foci in the pleural effusion, you know that is because of the thin film of pleural effusion is because of metastatic pleural disease. So for brain mets, as Amit said, MRI is the most sensitive modality. MRI is better than CT scan. MRI is better than PET alone. So even if you combine that PET and CT, MRI retains that superiority over a combined PET CT, even if you give contrast. So a negative PET CT does not obviate the need for dedicated brain imaging with MRI. That's something which you need to know. So if a PET scan is negative for the brain, doesn't mean that there are no brain mets. So this is an example of a lung cancer with brainstem mets. You can see that there's absolutely no uptake on PET scan. Whereas this is another case where on CT, part of the PET CT, you can see a lesion with edema, and it is intensely FDG avid. So you can have brain FDG avid metastases, or you can have metastases which are not FDG avid and not picked up on the CT part of it. So basically you can have a mixed bag, so you have to rely on MRI. So to summarize, FDG PET has an established role primarily for M staging, though for brain metastases, MRI is the preferred modality. For N staging, if you just purely look at diagnostic accuracy, PET is better than CT, but still needs mediastinal nodal sampling. For T staging, PET has no additional incremental value over a contrast enhanced CT scan, except in some situations which I mentioned. And it's recommended by all guidelines for staging of lung cancer. Thank you for your attention. I think your mic. I can't hear you, sorry. I think the mic.
Hi, sir. Sir, I'm Dr. Shipra, medical oncology third year resident. Sir, correct me if I'm wrong. I just want to understand the concept. A patient is there, 1 centimeter lung nodule is there, let's say on X-ray or some HRCT or scan somebody done outside, and I suspect it is carcinoma. I get a PET CT done first. There is a lesion.
Why are you getting a PET CT done?
I want to know. That's what I'm saying. So let's say the
So we are not talking about staging. Now we are gone to the diagnostic use of PET for diagnosis. Okay.
Algorithm, yes. Let's say the PET CT is done. Maybe it is done outside. We can also say on the baseline somebody got a PET CT done outside. Patient is referred to me. Yet the biopsy is not done. I got a biopsy done. It came out to be, let's say, neuroendocrine carcinoma. So my doubt is, in the first, when we did a FDG PET, then do we need to do a DOTA NOT or some other PET right now, or what do we do now, like, for the further evaluation?
So if I understand the question, FDG was positive for the lung nodule.
Lung nodule.
Then you did a biopsy,
Right.
which showed neuroendocrine carcinoma.
Agreed.
And now your question is, because it's a neuroendocrine carcinoma, do we need to stage it with
Again,
a somatostatin receptor imaging PET scan, which is DOTA PET, correct?
Correct, sir.
So if it is a carcinoma, then
High
DOTA,
chances
then if it's a carcinoma in histopathology, then DOTA PET is not going to add any incremental value. Now this has been proven for neuroendocrine tumors of the GEP. In lung, there is not much of data, but if you have a carcinoma with a MIB index, which is very high, if you look at the flip-flop phenomenon, the DOTA uptake goes on decreasing,
and the FDG
and the FDG uptake goes on increasing. So with a carcinoma, a reasonably high MIB index, your FDG is good enough to stage it. Yeah.
If it is a lower grade tumor,
If it is a neuroendocrine, if it is a carcinoid with like for example in lung, they don't give they would give you a mitotic index and typical or atypical ones. So if it is a carcinoid, then I think you probably need to do a DOTA, though it is not mandatory right now. If it is a typical carcinoid, your incidence of distant metastases is probably less than 3-4%. If it's an atypical carcinoid, high mitotic index, where at least in our data, we found about 12% incidence of metastases in atypical carcinoid, around 12 to 15%, which is reasonably high, then probably you need to do a staging DOTA PET scan. So it depends again, if it's a peripherally situated small typical carcinoid, you possibly can get away with not doing a DOTA. It's an atypical one, chances of mets are more than 10%, probably you need to do a DOTA then.
And sir, do we do a biopsy first and then you do a PET scan, or you would like to do a PET scan first to find a suitable site of biopsy and then?
So at least in a hospital setting, 90% of patients who come for PET scan are diagnosed. I don't think, see, that's a situation for where you need PET to guide biopsy is not a very frequent, you don't need PET scans frequently to know which is the area which needs to be biopsied. CT scan will tell you, if there is a necrotic center, mostly it will tell you. If you have biopsies which are negative on CT scan, and then probably you can use a PET scan to just direct or guide the biopsy. By and large, you don't need to do a PET scan just to direct or guide the biopsy in every case. It should be reserved in situations where routine biopsies are negative.
Thank you. Thank you so much, sir.
Yeah.
Good morning, sir. Let's say my patient having T4N2 or single station or less than 3 centimeter in FDG PET. So, according to the FDG PET criteria, do you use any certain characteristic in your findings that that can help me to avoid the histological diagnosis, whether I should go for a surgical resection? I mean, any SUV criteria should I follow? That this must be, positive and that can change my treatment plan.
So
Because it has.
So essentially your question is if PET scan shows positivity, then can we avoid invasive sampling?
Any particular characteristic from a FDG point of view, sir?
Yeah. So if you look at literature, there will be several papers which will tell you different SUV cutoffs. That above SUV cutoff, it has this much probability. Above SUV cutoff of 6, this has this much probability. According to me, it does not matter. If FDG positivity could, even if we have seen tuberculosis with SUV uptakes of 30 and lung cancers with SUV uptake of 2. So in my experience, SUV, high SUV, low SUV does not matter.
Sir, because there are 2-3 papers published in the ESCO, they have mentioned that more than 5 SUV of 5 max is, we can consider it as a positive for malignancy.
Even I have published papers, because you can't publish a paper without writing some value, but in real practice, I don't believe in it.
Okay.
And those papers probably would be from, European, Scandinavian countries where there is no incidence of granulomatous or
Yes, okay.
inflammatory diseases. But from this region, at least for the last 20 years, I believe that PET positivity does not really add. Now, if you really want to avoid a biopsy, I would look at the CT characteristic also. If there is a large node on CT scan, which is PET positive, shows irregular borders, central necrosis, which looks very much like the primary, then in those I would rely on morphology equally or probably more than I would rely on FDG uptake if I want to avoid a mediastinal invasive staging. I would say that, but we have our surgeons who would still go ahead, and Virendra, I think, is there. Yeah. He is not going to operate on anything unless he gets some histological, whatever we say, he is not going to operate unless he gets some either EBUS or mediastinoscopy.
Sir, one question. How to assess PET response after, while patient is on immunotherapy? Because certainly we can see that there is response in primary, but there is uptake in nodes. So
Amit, I think this is a staging lecture. We have gone to response evaluation and immunotherapeutic responses.
Okay. Okay, thank you.
Yeah, I mean, it's an entire conference by itself. It's not as simple. But yeah, there are ways to assess response on immunotherapy also. Thanks.